Phosphate is the major anion in the intercellular fluid. Although elemental phosphorus is an essential mineral, it is never found as a free element in nature because of its high reactivity. Phosphorus is found in the body in combination with oxygen and as phosphate. The average American diet is high in phosphorus, 1 to 2 grams per day. It is plentiful in meats, fish, poultry, milk products, and legumes. Although the term phosphorus and phosphate are often used interchangeably, laboratory tests actually measure the amount of elemental phosphorus, not phosphate, in the blood, which may be confusing. Phosphate is excreted from the body in the urine and stool. Approximately 85% of the phosphate in the body is bound with calcium in the teeth and bones. The remaining is located primarily inside the cells. The primary functions of phosphorus are listed on this slide. Phosphate imbalances occur when there is an increase or decrease in phosphorus content of the blood. Calcium imbalances almost always accompany phosphorus imbalances. Manifestations of hypophosphatemia may not be apparent unless serum levels decrease to about 1 milligram per deciliter. The most dangerous problems associated with hypophosphatemia are related to hypercalcemia, which can lead to severe cardiovascular and neuromuscular problems. Hyperphosphatemia, or phosphate excess, is relatively rare, except in patients with severe renal dysfunction. Dialysis does not reduce the risk of hyperphosphatemia because dialysis does not remove phosphate efficiently. High phosphate levels are usually well tolerated, but the accompanying hypocalcemia causes problems. Phosphorus and calcium have an inverse relationship in the body. When serum phosphorus levels are elevated, serum calcium levels are decreased, and vice versa. High serum phosphorus levels decrease the movement of calcium from bones, causing hypocalcemia. Low serum phosphorus levels increase the movement of calcium from bones, causing hypercalcemia. Both phosphorus and calcium are regulated by the parathyroid hormone, or PTH, and calcitrol, the active form of vitamin D. PTH is secreted by the parathyroid glands when serum calcium levels are low. PTH increases serum calcium levels and decreases serum phosphorus levels to maintain the calcium phosphorus levels in the body. Calcitrol is needed for gastrointestinal absorption and renal reabsorption of both calcium and phosphorus. Thus, vitamin D deficiency results in a decrease of both calcium and phosphorus in the body. Hyperphosphatemia does not routinely produce signs and symptoms. Manifestations are most often due to the underlying disorder causing the imbalance and other associated electrolyte abnormalities. Phosphate imbalances may be caused by actual or relative increases or decreases in phosphorus. An actual increase or decrease may be caused by phosphorus gain or loss, excessive intake or absorption, and increase or decrease renal excretion. A relative increase or decrease occurs when phosphate shifts back and forth between intracellular and extracellular compartments. When phosphate shifts into the intracellular compartment, hypophosphatemia occurs. When phosphate shifts out of the cells and into extracellular fluid, hyperphosphatemia occurs. Actual hypophosphatemia or phosphorus loss can occur due to vomiting, diarrhea, steatorrhea, and prolonged gastric suctioning. Severe burns and the associated release of catecholamines decrease serum phosphorus levels. The maximal loss occurs between days 2 and 5 after the burn. Despite aggressive phosphorus supplementation, serum phosphorus levels rarely return to normal before day 10 after a burn. Inadequate intake of phosphorus is another cause of actual hypophosphatemia, as seen in malnutrition, starvation, prolonged NPO status, administration of TPN in the absence of adequate phosphorus levels, or phosphorus supplementation is yet another cause of acute hypophosphatemia. Alcohol abuse, which results in poor nutritional intake of phosphorus and other minerals, as well as vomiting, diarrhea, and antacid use, also can result in hypophosphatemia. Impaired absorption of phosphorus, as seen in hyperparathyroidism, caused by oversecretion of parathyroid hormone, is the most common cause of increased renal phosphate excretion, resulting in hypophosphatemia. Vitamin D and E deficiencies can contribute to hypophosphatemia by failing to stimulate phosphate absorption. Malabsorption syndromes such as celiac disease or Crohn's disease also result in hypophosphatemia. Antacids such as magnesium and aluminum containing antacids bind with phosphorus, inhibiting absorption. Certain medications such as corticosteroids, loop diuretics, and thiazide diuretics cause an increase in phosphate excretion as they act on the kidneys to increase urine output. Hyperglycemia causes an increase in the urinary loss of phosphorus. Relative hypophosphatemia can be caused by fluid excess, which results in the dilution of phosphorus ions without an actual decrease in the amount of phosphorus in the body. Phosphate shifting into the intercellular compartment, as seen when the administration of concentrated glucose solutions, results in the release of insulin, causing glucose and phosphorus to move into the cells. Acute respiratory alkalosis, only caused by hyperventilation, causes phosphorus to move out of the cells and into the extracellular fluid compartment. Catecholamines such as epinephrine and dopamine, and hormones such as glucagon and calcitonin also cause phosphate to shift into the cells, resulting in a relative decrease in serum phosphate levels. Actual hyperphosphatemia, or phosphate gain, is caused by excess IV phosphate infusion, excessive dietary intake or supplement, feeding infants cow's milk instead of breast milk, as well as excessive use of phosphate-containing laxatives or enemas such as phosphosoda. Low PTH levels, as seen in hypoparathyroidism, and high vitamin D levels enhance phosphate absorption in the renal proximal tubules, resulting in the retention of phosphorus. Decreased excretion of phosphate, as seen in chronic glomerular nephritis, renal insufficiency, acute renal injury, and chronic kidney disease, decrease the kidney's ability to excrete phosphorus, is yet another cause of actual hyperphosphatemia. Relative hyperphosphatemia is caused by fluid volume deficit, resulting in the hemoconcentration of phosphorus and other electrolytes. Without an actual increase in the amount of phosphorus in the body, phosphate shifts into the extracellular compartments, also causes a relative hyperphosphatemia, as seen when cells damage occurs as a result of crush injuries or tissue trauma or severe infections. Rhabdomyolysis, the breakdown of muscle, results in the release of muscle fiber contents, myoglobin, into the bloodstream. This frequently results in kidney damage, or failure is another cause of relative hyperphosphatemia. The nurse should conduct a focused nursing assessment for phosphate imbalance, beginning with a thorough nursing history. However, because most patients with hypophosphatemia are asymptomatic, the history alone rarely indicates the possibility of hypophosphatemia. Assess each body system, observing for signs and symptoms of phosphorus imbalances. Measure and record the patient's vital signs and review the patient's laboratory data to assess for the presence of hypo or hyperphosphatemia. Interview the patient and family members to identify any risk factors or pre-existing conditions that would contribute to phosphate imbalance, such as vomiting, nasogastric suctioning, diarrhea, acute kidney injury, chronic kidney disease, or other conditions associated with phosphorus loss or gain. The nurse should also assess the patient's ability to drink and tolerate oral fluids. Include a current dietary history, inquiring about dietary habits. The nursing history should also include lifestyle factors such as long-standing alcohol use and chronic malnutrition and current medications, including excessive antacid use or the intake of glucocorticoids or chemotherapeutic agents. A thorough physical assessment is necessary because hyperphosphatemia is associated with hypocalcemia. Thus, the patient should be asked about recent muscle cramps, bone pain, or fractures. Monitor for the cardiovascular changes. Auscultate the apical pulse. Palpate peripheral pulses. Check orthostatic blood pressure. Observe for ECG changes. Monitor for cerebral changes. Establish the patient's usual cognitive and behavior pattern. Observe the patient's behavior, level of consciousness, and mental status. Monitor for seizure activity. Monitor for neuromuscular changes. Establish a baseline for the patient's muscle strength and tone. Monitor the patient for paresthesis, muscle weakness, muscle twitching, and irregular muscle contractions during each nursing shift. Monitor the patient's serum phosphorus level as ordered by the healthcare provider. Monitor other laboratory values associated with phosphate imbalances, such as calcium, blood urea nitrogen or BUN, and creatinine. Dietary management of hypophosphatemia includes increasing phosphorus intake and decreasing calcium intake. All medications that promote phosphate loss should be discontinued. Medications, either given orally or IV, should be administered as ordered to increase phosphorus levels. Treating hyperphosphatemia includes discontinuing medications or preparations that contain phosphorus, as well as decreasing dietary intake of phosphorus. Saline diuresis can assist in dilution and increase the excretion of phosphate. Diuretics such as Diamox that act on the proximal tubules to decrease total serum phosphorus should be administered. Also, phosphate binders to decrease serum phosphorus levels by reducing the absorption of phosphorus should be administered, such as Alternagel, Amphigel, or calcium carbonate, which is the medication most commonly prescribed for hyperphosphatemia. The priority goal for the patient is safety. Interventions include reducing environmental stimuli by providing a quiet room, limiting the patient's visitors, darkening the patient's room, and speaking in soft tones. Implement seizure precautions related to hyperphosphatemia and hypophosphatemia, including padding the side rails, having oxygen and suction equipment available at the bedside, and making sure the patient has a patent IV. Implement fall precautions related to muscle weakness caused by hypophosphatemia and hypercalcemia, which include performing a fall risk assessment, maintaining the bed in low position with locked wheels, removing all obstacles from the pathways, especially to the toilet, monitoring the environment for safety hazards such as torn carpeting or liquid spills on the floor, place assistive devices such as walkers and canes within the patient's reach at the side of the bed, use night lights, instruct the patient to request assistance to ambulate, assess the patient's footwear, and provide appropriate footwear if necessary. Patient must use anti-skid soles. Keep items such as telephone and fluids close to the patient. Request family members to remain with the patient if necessary. Position the patient to allow close observation by staff members. Communicate the patient's fall risks during shift report. Teach the patient or caregiver the causes of phosphate deficiency. Provide specific information regarding the patient's medical diagnosis and related interventions or treatments. Teach the patient how to identify signs and symptoms of phosphate deficiency. Instruct the patient and family to notify the primary health care provider if the patient exhibits signs or symptoms of hypophosphatemia or if they have any specific concerns. Teach the patient how to prevent phosphate deficiency. Teach the patient about foods that contain phosphorus. Instruct the patient to decrease calcium intake by avoiding high calcium foods such as milk, cheese, yogurt, collard greens, and rhubarb. Teach the patient how to take oral phosphate supplements. Instruct the patient to report adverse effects such as nausea, vomiting, diarrhea, and abdominal cramping to the primary health care provider. Encourage the patient to keep appointments for laboratory studies to evaluate serum phosphate levels. Ensure the patient or caregiver understands the specific rationale potential side effects of the treatment regime. Include medication administration, nutrition, hydration, dietary restrictions, and foods high in phosphorus in your patient teaching. For patients with hyperphosphatemia, teach the causes of phosphate excess. Provide specific information regarding the patient's medical diagnosis and related interventions and treatments. Teach the patient how to identify signs and symptoms of phosphate excess. Instruct the patient and family to notify the primary health care provider if the patient exhibits signs or symptoms of hyperphosphatemia or if they have any other specific concerns. Teach the patient how to prevent phosphate excess by avoiding foods high in phosphorus. They should avoid processed foods may have hidden sources of phosphorus. Instruct the patient to increase their calcium intake. Also teach the patient and family how to read food labels, which lists the amount of phosphorus containing in each serving. Encourage the patient to keep appointments for laboratory studies to evaluate serum phosphorus levels. Ensure the patient and caregiver understand the specifics, the rationale, potential side effects, and desired effects of the treatment regime. Include medication administration, nutrition, hydration, dietary restrictions, and foods high in phosphorus in patient teaching. Listing of foods high in phosphorus. Document all assessment findings and intervention per facility policy. Evaluate and document the patient's, caregiver, and/or family members' response to intervention and education.